adolescents. As Dr. Anita has already pointed out, it's very, very special and we need not to overdiagnose. So PCOS is the most common endocrine disorder seen in women associated with significant health problems, impaired reproductive health, psychosocial dysfunction, metabolic syndrome, cardiovascular morbidity, and different cancers. It's already been highlighted by Dr. Anita so beautifully. So etiology pathogenesis is not well understood. It's a complex genetic and environmental factors. Accepted theories are disordered neuroendocrine gonadotropic secretions, hyperandrogenism. Is it a part of it or is it the cause of it? Same is insulin resistance and hyperinsulinemia, or a combination of both. Maybe they are because of it, or PCOS is because of hyperinsulinemia or insulin resistance present. Many have ovarian hyperandrogenism as primary dysfunction associated with hyperinsulinemia and insulin resistant with increased LH and obesity. Thus, it has an heterogeneous causes. So there are different PCS phenotypes have been described by NIH, that is National Institute of Health, in 1990 and 2012. They have been associated that it's androgen excess and ovarian dysfunction, or androgen excess with PCOM or ovarian dysfunction, and all the three present. So NIH in 2012 said all four phenotypes could be present, but Androgen Excess Society believes only in androgen excess, so it has omitted PCOM plus ovarian disorders. Rotterdam is same as 2012. So the case presentation is a 16-year-old girl presenting with 3 months amenorrhea with past history of puberty and menarche at 12 years, previous cycles every 2 to 3 months lasting for 2 to 3 days with light blood flow, only 3 cycles in the last year. Overweight since childhood and a rapid gain over the past 4 to 5 years, history of coarse dark hair on face and lower abdomen, which have progressively increased over last 2 to 4 years. She is now shaving every 3rd day and progressively worsening acne on face and back. BMI is 38, BP is 140/90, acne, hirsutism and acanthosis nigricans present, no Cushingoid features, rest physical examination is normal. On lab evaluation, LFT is normal, lipid profile normal, cholesterol 200, raised triglycerides were seen. Endocrine testing was LH 20, FSH 12, testosterone 70, and DHEA is 225 micrograms. Her CBC blood sugar was impaired, 106, postprandial was 150, and HbA1c was 5.9. So I come to the questions. What is your diagnosis and diagnostic criteria, Dr. Seema?
Thank you, Dr. Vandana ma'am. As you presented the case, she's a 16-year-old girl, adolescent girl, and you already highlighted the diagnostic criteria. So if we see those criteria, she has features of oligoanovulation, she has irregular cycles, she has features of androgen excess, like she has hirsutism, she has the acanthosis nigricans, she has no Cushingoid features. So we rule out the other causes of hyperandrogenism besides PCOS.
Right.
So, and also the lab investigations collaborate the fact that she fits into the category of a polycystic ovary syndrome. And the diagnostic criteria, you already highlighted the laboratory investigation. All of them point towards a diagnosis of polycystic ovary syndrome in this girl.
So in adolescent presentation, the challenges are how to differentiate between normal physiological adolescent anovulation from true ovulatory dysfunction. Signs of androgen excess as mild hirsutism and acne is commonly seen in peripubertal age. Normative testosterone levels have been ill-defined in this age group, and normal adolescent ovarian morphology is overlapping, and we have already seen it is not to be used. So presentation in adolescent, it presents with ovulatory dysfunction. First year post-menarchal, it has already been described that any menstrual period greater than 90 days, and 2 years post-menarchal, it could be less than 21 or 40, greater than 45 days. And primary amenorrhea if the girl is 15 years of age or she has had thelarche 2 to 3 years back. And PCOM is not recommended as a diagnostic criteria in adolescents because of overlap. So adolescents are presenting mainly with ovulatory dysfunction and androgen excess. So ovulatory dysfunction we see as menstrual disorders, and androgen excess can be seen as moderate to severe hirsutism, persistent acne. So mild hirsutism is not considered as androgen excess. Persistent acne unresponsive to topical therapy, evaluated for hyperandrogenemia. So the patient has to be evaluated for hyperandrogenemia before any medical therapy has been given. And persistent elevation of total or free testosterone greater than 55 nanograms per deciliter. So we have to see that the patient is uh, uh, falling into this criteria, or maybe we go do a modified Ferryman Galloway score. So a definitive diagnosis of PCOS is not needed to initiate treatment. Treatment may decrease risk of future comorbidity even in the absence of a definite diagnosis. This is for adolescents. So deferring the diagnosis of PCOS while offering symptomatic treatment and providing regular and frequent follow-up of symptomatology is recommended. Obesity, hyperinsulinemia, and insulin resistance are recognized as a common in adolescent with PCOS, but these features should not be used for diagnostic purposes. So diagnostic purpose only ovulatory dysfunction and androgen excess. Other causes of hyperandrogenemia and irregular menstrual period must be ruled out before a diagnosis of PCOS is established in adolescents. So the clinical features is again abnormal menstrual period, hirsutism or acne. Stepwise diagnostic approach is recommended. History should include review of exogenous medication intake. That androgenic steroids, maybe the patient is on some, and some anti-seizure medication may cause clinical features similar to PCOS, and acne medication may mask PCOS features. So history, very important. We need to take history, what she's taking or not. So menstrual irregularity we have already defined again, and the only other point I need to highlight is menorrhagia also. Although it is been saying it is oligoannulation, but menorrhagia accounts for 33% admissions in adolescent age group in with polycystic ovarian disease. So hyperandrogenemia, hirsutism, Ferryman-Galloway score greater than 4 or greater than 8 according to the ethnicity. And acne severity categorized as mild, moderate, severe based on lesion type. Severity and progression of both features is to be followed. DD with other causes of virilization has to be ruled out. Thyroid dysfunction has to be ruled out. And elevated prolactin and hypercortisolemia also has to be ruled out. So another question, what lab evaluations are specific for the diagnosis of PCOS in adolescents? So who's answering? Who's taking up this question? Lab evaluations?
Unmute yourself now, Dr. Neerja. Unmute yourself.
Okay. Yeah. We have classified the lab investigation into two categories, which are essential and desirable. The essential, like already highlighted, but we have to add serum TSH, prolactin, and lipid profile we have already done in this patient, and testosterone levels also have been done. And we can do 17 hydroxyprogesterone also has to be done as desirable, as essential, along with OGTT. OGTT is to be done so that we can rule out insulin resistance also and her chances of developing diabetes. And it has to be done every 1 or 3 years. And desirable are DHEA, serum androstenedione, and LHFSH ratio is also not essential in adolescent. It is a desirable thing. We can also do fasting insulin levels. Vitamin D3 can also be done. And one more thing, free androgen index should also is a better indicator rather than testosterone, because the free direct levels are sometimes not specific in adolescents. So free androgen index is calculated by definition like total testosterone divided by sex hormone binding globulin into 100. That is a more better indicator.
Right.
And we can assess this girl for her hypertension, then obstructive sleep apnea, as Anita has highlighted already. Then for her body image issues, like her eating disorders, for that we can do the SCOFF test. And then we have to assess her for anxiety and depressive symptomology, and quality of life should also be emphasized on these girls.
Right, right.
So this is all we have to evaluate, and psychosocial evaluation and all these things has to be done.
Very, very essential for an adolescent girl, because she's just stepping into adolescence and she's got that body image problem. She's obese, she's hirsute. So she's very, very conscious about her body image, and she has a negative, which has a negative impact on her health, and she will again keep on having eating disorders. So those issues have to be really be addressed. So hyperandrogenemia demonstrated by free or total testosterone DHEAS level screens adrenals as a source of hyperandrogenism. The samples have to be taken in the morning, and normal afternoon levels do not exclude hyperandrogenemia. So these different androgens, like we have free and total androgens, it's very difficult to measure free androgens. And as Dr. Neerja has already said, that we can take free androgen index. DHEA androstenedione comes from testosterone in a PCOS woman girl is coming from ovaries, and androstenedione is coming from ovaries and adrenals both, and DHEA is very specific to adrenals. So that is the reason why we are doing DHEA levels, and 17-hydroxyprogesterone also is coming from adrenals. So they differentiate from other causes of hyperandrogenism in an adolescent girls. So additional investigations could be TSH and LH-FSH, prolactin, androstenedione, and 17-hydroxyprogesterone, which can screen for non-classic congenital adrenal hyperplasia if the levels are greater than 200 milligrams per deciliter. So psychological evaluation is of great importance, because psychological morbidity has to be evaluated. Anxiety and depression is common. Validated tools have to be used for screening, and clinical and subclinical eating disorders are very common in adolescents and require empathetic lifestyle counseling. So now, what is the role of pelvic ultrasound in diagnosis of PCOS in adolescents? Dr. Kirti, I think?
Yes, ma'am. Good
Yeah.
evening, ma'am. Thank you for asking me this. Actually, ma'am, if you'll ask me whether to do an ultrasound or not in an adolescent girl, though it is not indicative of any PCOD, it's not necessary, but one has to rule out other things, so one has to do an ultrasound.
Yeah.
I mean, आज मैं अनीता राजौरिया मैम ने भी इतना बताया है कि ultrasound is not the only criteria, and even if you see bulky ovaries और वही जो peripherally enlarged हम multiple follicles पढ़ते आए हैं अभी तक, though it is not the criteria for diagnosis of this thing, but in a young girl, adolescent girl, doing a pelvic ultrasound is important. You have to rule out other things also. There should not be any congenital adrenal hyperplasia, koi aur pelvic tumor to nahi hai, there is some other cyst or not. So one has to do an ultrasound. It is important.
Very, very, very good. So not recommended for diagnosis of PCOS in adolescents, and clinically indicated. But when clinically indicated, ultrasound has to be done to rule out other underlying pathology. Very nicely said, Dr. Kirti. Some experts suggest to exclude rare causes of androgen producing tumors in adolescents presenting with anovulatory symptoms and hyperandrogenemia. So, Dr. Kirti, again, what are the comorbidities associated with PCOS in adolescents?
And comorbidities like others, Neerja ma'am has also said, and you have been also explaining, the first and most important or most commonly occurring comorbidity in a PCOS is like she's generally obese. Like thin PCOS are also there, but obesity is very common. When the patient walks into your clinic itself, you can come to know through her appearance, she'll be little obese, she'll have hair growth over her body, then she'll have this acanthosis nigricans. Means the वही है ना कि clinical diagnosis also, you generally I have seen like lots of lab tests are also there, but these comorbidity conditions like she will have insulin resistance, she will have acanthosis, she will have acne, she will be obese, then she's more prone to have other hormonal imbalance like thyroid, hyperprolactinemia is very common, ma'am. I don't know why, but in my practice I always get prolactin as well as TSH done, and for people now I get more of increased prolactin levels. That's mainly because everybody has an altered this sleeping cycle, so that's why the prolactin levels are now, I find in a lot of patients without any other abnormality there is a hyperprolactinemia. So
I want to interrupt you, Kirti, for this particular thing.
Yes, ma'am.
Because
Yes, ma'am.
hyperprolactinemia is sometimes it is a faulty report, because proper serum prolactin is not done very carefully in all the labs. And I think you take one sample. I have seen so many times that very high prolactin level to the tune of 118 or something, and then you get it repeated and it comes out to be normal.
It is not like a
value of prolactin is
It has
not
to be done in pooled levels, no? It has
pool
to be
level
done in
करा लो
pooled
या फिर
cycles,
अगर
yeah.
कोई उसके संग there is some associated problem, then only correlate with it.
Even drug intake is very common, which results in hyperprolactinemia. So one should be careful in taking the history of drug intake.
PPIs, patients are taking PPIs so commonly and they do land up with hyperprolactinemia.
हाँ उनमें तो होता है ये mostly.
Even hypothyroid patients can have
Hypothyroid is associated. Yeah,
Hypothyroid is
That is
associated
high
with
hyperprolactinemia.
hypothyroidism, prolactinemia will disappear.
is also
100.
you see that.
Yeah. So PCOS is associated with significant metabolic and psychological morbidity, metabolic syndrome, insulin resistance and hyperinsulinemia, and type 2 diabetes mellitus, impaired glucose tolerance screened by 2-hour OGTT, and obesity and overweight confers additional risk. And this patient of ours already has 38 BMI. So now we come to the management. Dr. Ila, highlight how will you manage?
Thank you so much, Vandana, for taking me in this panel. And I just want to say that we are managing PCOS patients day in, day out. And there are so many things which we have become accustomed to deal with. Like the most important thing is the counseling part. That every patient who comes to your clinic, first of all, you have to counsel her regarding, after making a diagnosis of PCOS, you know that it is a case of PCOS. Then first of all, you have to sort of remove their worry, anxiety regarding PCOS. Though it is a very, very difficult syndrome which has to be managed lifelong, like a diabetes mellitus or something like that. But at least the anxiety in the patient and patient's mother's mind is too high. So first of all, relieve that anxiety by saying that treatment is very simple, though you have to be persistent with it. So lifestyle management is the first and most important thing which you have to do. And that is also, you have to tell them how many hours of exercise she has to do. If she does a vigorous exercise, then at least 75 to 150 minutes per hour per week, or she has to go for the 150 minutes per week for at least like that, half an hour for 5 days a week. She should do good exercise. And if adolescent is energetic enough to do exercise, then 60 minutes per day will be a good option for them to do regular exercises. Secondly, they have to be told about the weight reduction, because weight reduction is must in these cases. If you do not reduce the weight, then it is a persistent problem, and this is of course associated with so many comorbidities. So weight reduction should be taken as a program in her life, whether you have to involve various people in the loop, like physiotherapist or dietitian, and it should be dealt in a very effective way so that she is capable of reducing weight. Along with that, you have to avoid talking about the body image or something. You should not give her feel that, look, you are obese and how are you looking and what else. So you have to be very empathetic with them. And so one should be very, very careful in dealing with such girls.
Adolescents.
Be very affectionate, very caring, so that they consider your things very efficient, very, very effectively. So that is very, very important. Lifestyle management, and then exercise is also important. Like apart from the diet control, which you have to tell in the form of diet also, like what calories and how to take it, and what things to be avoided. We can tell them as we avoid diet, prescribe the diet in diabetic patients. Likewise, we tell her to avoid carbohydrates less and high protein diet with a lot of water intake and all those things. Fiber intake has to be increased in such cases. Then we come to the pharmacotherapy. As we know that this girl is, I think, 16 years old.
She's 16, yeah.
So, and we have diagnosed her as a PCOS. So we can start with oral contraceptive medicines, because this is the first line of treatment in these patients. But of course, along with that, she has a slightly altered diabetic profile. So it becomes important that we can add on metformin in this case. Suppose we can do it like this, that we start with the
She's 16.
series for initial 6 months, and suppose she doesn't have a weight reduction, or she is not fulfilling the criteria in those forms, then of course we can add a metformin along with it. I have seen in my practice that I usually give metformin in such cases, and it gives a very good results as far as the weight reduction is concerned. Though first line of treatment is COCs, but metformin also very effective in such cases. So I believe that these two things are very, very important, and along with the exercise and all those things, she has to really, really stick to the lifestyle. That is the most important management in such cases.
Very nicely said. So lifestyle and pharmacotherapy are the basis, and treatment option have to be individualized according to presentation, needs, and preference. Goals of treatment are to improve the quality of life and long-term health outcomes. This is a line which has to be emphasized in an adult, and we have to tell them that this is a lifestyle disorder. If you take your lifestyle in control, maybe we are putting you on medication today, we'll withdraw everything. So that is a very big reassurance for her. She would get a window of opportunity, window of period where she would be disease free as long as her lifestyle stays under control. The moment things start going haywire, again she will go back to the same presentation, and we might have to add pharmacotherapy. So is the first improve with lifestyle we can improve menstrual regularity, decrease cardiometabolic risk, and improve androgen excess can all be achieved with a 5 to 7% weight loss. So energy deficit of 30% is required, and exercise recommendations are 150 minutes per week of moderate intensity physical activity or 75 minutes per week vigorous intensity, and muscle strengthening activities on 2 non-consecutive days per week. And for modest weight loss, prevention of weight and weight regain, greater health benefits, we have to see that the patient continues her exercise. 250 minutes per week of moderate intensity or 150 minutes per week of vigorous intensity and muscle strengthening activities on 2 non-consecutive days per week can be recommended. Pharmacotherapy, as all very well said, COCs are recommended, and COCs not with cyproteron, as has been already highlighted by Dr. Neeta. The first line are we can use with COC with desogestrel or levonorgestrel. And then this regulates menstrual irregularities including amenorrhea, oligomenorrhea, menorrhagia, and abnormal uterine bleeding. Improvement is usually seen in 2 to 3 months, and duration of 1 or more years with a break to allow HPO excess recovery and observe spontaneous menstrual irregularity. The duration of treatment per se is dependent upon tailored according to the patient's requirement. So COC addresses hyperandrogenemia, it suppresses HPO excess and interrupts the pathophysiologic mechanism of PCOS, resulting in reduced ovarian androgen production, increasing SHBG, further reducing androgens. Hyperandrogenemia reduces and testosterone levels can be rechecked if required for reassurance. Otherwise, it is not recommended after 3 months. Cutaneous manifestations of hyperandrogenism, that is acne and hirsutism, both show improvement, and improvement we see within 2 to 3 months. So metformin is recommended when PCOS associated with impaired glucose tolerance and type 2 diabetes mellitus who do not improve on lifestyle. For hirsutism, both COC and metformin are equally effective. Metformin is better in weight reduction and improves dysglycemia than COC. So for hirsutism, both COC and metformin can be given in a combined. We can add metformin to it.
One point I want to say, that any COC can be effective. It doesn't matter
Any
whether it
COC,
is less than 30 or
yeah,
more than 30 estrogen.
yeah.
Every COC is effective.
See, we use a standard dose. We don't use a very low dose COC in adolescent because the reproductive organs are being maturing. So we do not want to
Give
take
very
away
high
the
doses.
estrogen. We don't want to we don't want to use very low dose. We want to use standard dose. 30 micrograms, don't go below that. Okay. And we have already seen any COC will be reducing ovarian androgen production, increasing SHBG, and the mechanism of action I've given. That is the reason why I gave the mechanism of action. Okay, why the COC is giving. So we do not need to use cyproteron 1, which can be a second line if hirsutism is not improving. Metformin can be added, and for hirsutism, both COCs and metformin are equally effective. but metformin is better for weight reduction. What drugs can be used to help an adolescent with cutaneous manifestations? So, who's taking it?
I can take it now.
Yeah.
Since we've already started the patient on COCs,
Yeah.
these patients respond very well for the cutaneous manifestations. Hirsutism and acne improves within 3 to 6 months. We can see the response if the patient is on COCs. However, if she doesn't respond, we can add or substitute it with spironolactone with another anti-androgen. So, and if it still require, we can change over to finasteride or add it in a low dose, which is also very good.
Yes. Adjuncts are often required to addition to COC and metformin. Yeah. Anything else?
Yeah, that's all.
So adjuncts often required in addition to COC and metformin to improve cutaneous manifestations further if they are not improving after a trial of 3 to 6 months. Spironolactone can be added, is a potent anti-androgenic. It can improve the menstrual abnormalities also, and combination of metformin and spironolactone is superior to either drug used alone to improve menstrual irregularity, hirsutism, and serum androgen levels and insulin resistance also show improvement with metformin and spironolactone given together. Finasteride is another option. Intermittent low dose is effective for hirsutism in girls with PCOS or idiopathic hirsutism. So what additionally can be done to deal with facial hair, because the girl has got a very negative outlook about herself. She's hirsute, she's shying away, not going into her classes, or maybe she is not very comfortable. What all can be done? Okay.
Additionally, we can advise though the adolescents, they are already into this like cosmetic removal of the hair. They are already using electrolysis or laser hair removal or creams for cosmetic treatment. However, if they don't respond to this mechanical therapies, we can use creams like eflornithine, Flora drug cream, which can be applied, which slows down the process of hair growth. So she won't have that intense growth of hair on the face. This can be used as another method of hirsutism treatment.
Very rightly said, Dr. Seema, that cosmetic hair removal can be electrolysis, laser hair, but we have to be very careful when we are doing that Ferryman Galway score. We have to ask if the girl has already taken these cutaneous treatments. If she has taken, then we have to evaluate the Ferryman Galway score at least 3 months after electrolysis or laser. After waxing, it is to be 4 weeks, and after creams, it has to be 5 days. So the vaccine can also be prescribed, and eflornithine cream can be given. Eflornithine cream can be combined with laser to give rapid reduction. Also, we need to tell them that these hair would come back again if we stop the treatment, because the underlying pathology of underlying
it is not a cure.
It is not a cure. It is not a cure. These are just procedures which can keep her in check, and they might have to come back again and again because her androgen levels are the reason for her hairs. Thank you.